So yeah, topic of the stream tonight, the medical topic at least. I discovered on Friday, which was Residence Day, I discovered that Residence Day exists because everybody needs to be a special snowflake and have their participation trophy. So in honor of Residence Day, I figured it would be a good idea to talk about just how much life and working conditions in medical education sucks. Because it sucks really bad. And to have like, I don't know, to have a day celebrating like some of the most chronically overworked, undervalued, underpaid, underappreciated people in the country is totally asinine to me. So let's lay some ground rules and ground information for people who are unfamiliar with how this works. So medical education, basically you go to med school, you go to residency, which is residency is your training for whatever specialty you choose. You can do something called fellowship afterwards, which is like subspecialty training. So like if you do surgery, say, and you want to do cardiothoracic surgery, then you do general surgery, and then you do an additional cardiothoracic fellowship. And for me, I'm an anesthesiologist, so if I wanted to do pain medicine, I would do my 4 years of anesthesia residency and then 1 year pain medicine fellowship. And fellowships aren't all 1 year, like cardiothoracic surgery, for instance, is either 2 or 3 years, depending on where you go. But yeah, so you choose your specialty, you go into residency, which is anywhere from 3 to 7 years. Then you are a doctor, like you're functional, you're independent, and you can get a job, and life is good, you make money, and all that shit. So there are some guidelines for how you can work during both med school and residency. And I would say, so somebody will have to correct me if I'm wrong on this, but I am not aware of any specific work hours guidelines for med students outside of the ones that exist for residents. For residents, there's a funny story that goes something like this. Basically, there was a very wealthy person's daughter who had a bad outcome, supposedly at the hands of a sleep-deprived, overworked resident. And there's kind of some back and forth as to whether actually there was a medical error there that, made any difference, or, whether the patient's outcome was like kind of predetermined or what. But in any event, that's how the story goes, and that elicited this change where residents can now supposedly work no more than a total of 80 hours per week, averaged over a 4-week period. So note that doesn't mean that you can't work over 80 hours a week. It means that you can't average more than 80 hours a week over 4 weeks, right? So you could have like 1 week where you work 100 hours and 1 week where you work 60, but that averages out to 80. So that's okay. 80 hours a week is a lot. If you've ever worked an 80-hour week, you know how brutally ass-kicking that is. And to have that just sort of like be your norm, that's the standard you're trying to adhere to, is sort of a sad state of affairs, right? Like that's your goal. And let me tell you, that is not a goal that is achieved by some programs. Actually, probably a lot of programs. I can think of a few for sure. Do I think it will ever change? No, I don't. I do not think it will ever change because there's way too much money involved in it. It is evident to me that most hospitals value the income that residents generate over actual quality patient care. And we'll put a little finer point on that as the stream goes on. But residents make hospitals a lot of money, especially senior residents, like, who are trained and like more experienced and can like do shit. Like I don't know, maybe interns are kind of a wash. But still, I think interns function on the level of like a average mid-level provider pretty reliably, especially towards the end of their first year. So that's a money savings, because they're only about half as expensive as mid-level. Well, their salary is half of that of a mid-level, so they're actually probably, given that they work twice as much as a mid-level, they're probably about a quarter as expensive as mid-level, if that makes sense. So we'll try to approach this. There is so much wrong with medical education that it's really hard to know kind of where to start talking about it. Even though we're really just like only talking about like work hours, or at least that's the focus of the talk tonight. It's still just like, it's such a foobar shit show that it's just really tough to even like organize this. So since we're kind of talking about work hours, so we'll kind of flesh that out a little bit. So 80 hours a week, it's a lot, right? Why don't more doctors speak out against this? I don't know. I don't know. I don't have a good answer for you on that. You know, I think it's kind of starting to happen. So there is an organization that is sort of purportedly a residency union, like they're unionizing. But dude, you have no leverage, right? Like like residents don't have any leverage. They have no money. They have minimal connections, and we're talking about, you know, most of the places that have residencies are huge hospital complexes. You know, these are like billion-dollar businesses, and they've got, you know, obviously like healthcare is sort of fraught with you know, legal complications to begin with, so they all have like pretty powerful legal teams behind them. So this is it's a very there's tough opposition, there's big opponents, but attending should help them out. They should, right? But unfortunately, people in medicine are generally real stupid about everything but medicine. You know, and as far as like, you know, social justice and, you know, unionizing and stuff like that is, it's tough. And I think the culture is changing a lot. And yeah, attendings have the mindset of I did it, so should you. There is way too much of that in medicine. Just like there's this tradition of just beating each other down. And I think that's slowly changing. Like I think people who have graduated within the last, I don't know, say 10 years or so, are a little more prone to not behaving that way. Like, I think there's a substantial mindset change, but there's still so many who do behave that way. And so the inertia persists. And it's a huge problem. It's a huge, huge problem. So the hospitals are the oppositions? Yeah, absolutely. Yeah, for sure. Because they're the ones who don't want this to change. They don't want the system to change. Because they make a shit ton of money. So, like, well, to take the previous example, right? So I often jokingly, mostly jokingly, refer to mid-level practitioners as professional interns, because that's kind of what the job is, honestly. You do all of the, you know, kind of like admissions, noting, you know, chart work and stuff, and like rounds and all of that. Like, you're the frontline worker, basically. And if a resident isn't there to do that, that's what a nurse practitioner or a PA does. But yeah, so like if a resident works, then, you know, I worked more like 65-hour weeks. I didn't work 80-hour weeks during residency, on average. There were some weeks that I did, for sure. Some rotations I did. But so say 60 hours. We'll be generous and say 60-hour weeks. And a nurse practitioner is 40, right? Because they're actual employees and are not treated like dog shit most of the time. So right there, you have residents working 1.5 times as much. So as a resident, I made like 55 grand. Well, after a raise, my senior year, I got a huge raise. My senior year, like 25% raise, because our program was just like woefully underpaying us, even by comparison to other residency programs. So they changed that a little bit, and at least like raised us to the regional median, I think, which was like a 25+% raise. If you work 1.5 times as much and you make half as much as an NP, that means that the hospital's getting 3 times the value out of you. Plus, hospitals get, well, when I was going through, it was like just over $110,000 per resident, but the residents actually only cost them like 70-ish, mid-70s. So say they're making, on the conservative end, $30,000. They're just pocketing $30,000 per resident. Like, they just straight up make 30 G's from each resident. Plus, you have, like, increased productivity, because you can just work residents as hard as you want. You can, you know, call at all hours of the night and do whatever the hell you want to them, basically. Like, they're basically just, like, totally disregarded as professionals. I mean, you've already been through 4 years of medical education, dude. Like, you're a smart person when you're an intern. It's like there's a bunch of logistic problems, but you know, you're obviously trainable. So yeah, so to kind of further answer the question as to why I don't think hospitals will ever change residency, I mean, I think, one, they're too powerful. There's too much money in it, and residents are stuck in this like terrible bind, basically, where, you know, if you oppose the administration, you risk losing your spot, right? Or at least, at the very least, having a much, much, much more difficult residency. Like, if people are constantly breathing down your neck, there's a decent chance that they're going to find a way to, like, make your mistakes cost you dearly. And that's, you know, something you can't really afford, because you are going to make mistakes. Like, you're a learner, right? And the environment that you're in is you know, those mistakes are potentially dangerous. And if they make a case against you where you're like a patient safety risk, then you're done. You know, that is extremely difficult to combat. And again, we run into the fact that hospitals have these like massive legal teams, and you don't. You know, you like have basically every disadvantage. So if they want to hose you, they're going to. And I've heard that story play out a bunch of times. I may have seen that happen. I don't know for sure, but I've definitely heard of that happening across the country, time and time again. Like, if, you know, the squeaky wheel gets greased, basically, in the mobster sense. Yeah, so so we talked about the limitation on duty hours, right? And I mentioned that a lot of programs violate those, right? They violate the 80-hour rule thing. So yeah, like I said, I averaged about mid-60s hours, something like that, per week for most of residency. There was 1 or 2 rotations where I was, how is this fair? It's not fucking fair. It's also not safe. It's also not safe, which is kind of where we're going. So our 24-hour calls were brutal. Like, if you, I did not personally have a pedometer or like Fitbit or anything, but my friends who did, like the other residents, said that during our calls we walked like 12 plus miles, like 10, at least 10 plus miles every call. So like we were freaking busy all the time and just moving constantly. So just the walking is like, you know, quite a lot of exertion. And then on top of that, you're like expected to perform at a high level. Most of the time you were in like, you know, an operating room or like doing something else all day, because, you know, you get there at 6 in the morning and, you know, start working. You know, you're just kind of getting your ass handed to you the whole time. It's like the idea behind residency is that you see everything, you know, all the crazy shit. You're up late at night and like doing all of these intense cases and stuff, so that when you're out in the real world and practicing and those situations arise, you can handle it. But those sorts of things are the norm and not the exception in residency. And everybody just sort of, everybody around you just kind of like allows that to happen. So yeah, we would be very busy during the day, and then at night, like, you just kind of do whatever comes your way. Like, we had most anesthesia programs have residents do the cases in the operating room overnight. We did not. We had CRNAs do that, and the residents took care of everything else in the hospital, which is good for training, in my opinion, because sitting and staring at, you know, some trash case is not super educational, while, you know, going to traumas and managing codes. Code is when somebody like dies in the hospital, basically. Those are useful things. Those are useful to your training. What is that besides running code? So for us, it was responding to traumas, sometimes doing like emergent consults, like doing, you know, like intubations or something in the ICU, going to OB. If there was like a transplant or something, we would go see the transplant patient and work them up and get them ready for transplant. Just whatever showed up, on any random ass situations that could arise. But again, way more useful than any weird shit in the operating room. And if there was like, you know, a big trauma that came to the OR, we would be involved in that. Like, we'd be in the room helping out and getting started and stuff. But as far as just like sitting there and watching the patient, we weren't obligated to do that, unless like shit hit the fan and they just needed somebody in the room to like take care of a patient because there's other stuff going on. But that happened very rarely. I think that happened like maybe 2 or 3 times my whole residency. But yeah, they basically demand that you work, you know, full speed ahead at all times. And I've never worked harder. you just get your ass kicked constantly. And, you know, especially if you have a particularly rough call, like I would say we got about 2 to 3 hours of sleep spread out through the night. You know, so maybe in like 20-minute bursts, 30-minute bursts most of the time. And like, you know, if you were just getting rocked and you had a high-level case come in, like some trauma or, you know, something crazy emergent in the middle of the night, like, you were gassed, dude. Like, by 2-3 in the morning, you were not functioning well. Like, I do not believe I ever made a mistake or witnessed anybody make a mistake because of sleep deprivation, but you definitely function way slower. Your efficiency is poor. Like, everything takes a little bit longer, and, like, you know, your processing is not good. It's, you know, it's just a bad situation, and it's not ideal. And you don't really, like, learn from it, honestly. Like, you don't learn from it like the old guards say that you do. It's really the stuff that's kind of like after hours, but not in the middle of the night after you've gotten your ass handed to you for 20 hours. You know, so stuff that comes in at like 8 p.m. where you're like still kind of on the ball that you can learn from, but everything after that is just like, it's garbage time, dude. You're just trying to survive. And it's kind of sad that that's, you know, deemed okay. But is it better? Is residency better than third year? No. No, it is not. It is not at all better than third year. But yeah, residency as opposed to third year, like at least with third year, you don't really have, like, you kind of feel like an idiot all the time, but you don't really have any responsibility, right? Like at the end of the day, it's on the residents and fellows to like get shit straight. But yeah, overwork, even though it's not technically considered overwork by, you know, current legislative standards, in residency is rampant, basically universal. Hospitals are not afraid to use you as cheap labor because they can. And again, you can't do anything about it. You can't quit. You're basically obligated to stay there because, again, you can't change residencies very easily, like assuming it's even possible at all. So you're just sort of stuck with what you get. And that's a very daunting, sometimes harrowing reality that residents face. And, you know, if you lose out, you have hundreds of thousands of dollars of debt to pay for without a specialty. You know, like, you are massively up shit creek. So that's a very, very, very serious problem to have. So basically you can't do anything about it. You just got to eat it for the duration of your residency. And I hope that changes. And there are increasingly more physicians kind of getting on board with this, like, hey, residency's kind of bullshit. Maybe we should change these working conditions. Because again, overwork, like functional overwork where people are burning out, is commonplace. I mean, I would say it's the norm, honestly. And there's just no relief. Like, because you're expected to do this, you know, high volume of, like, very high level, important, potentially dangerous work, and then go home and study. And that's insane. That's total insanity. And, you know, these tests that you're studying for are extremely important. Like, if you don't pass, you don't have a career. I mean, you get a couple chances to pass, but still, like, you have to pass these tests or else you're out. You're done. I know 2 people who failed out of anesthesia because they couldn't pass their board exams. And the program just dismissed them because they could never get a medical license. So there's no reason to graduate anesthesia residency if you can't get a medical license. All of those things, the overwork, the poor pay, the bad conditions, all of those things have been, as far as I can tell, amplified dramatically by COVID. There's hospitals are basically telling people that they're going to work extra shifts. They're moving them to COVID units, and I don't know if there's been any, like, suspension of work hour standards or not. I doubt it, because that would probably be real hard to sell. But, you know, in any event, people have been, like, doing these just mind-numbing, like, COVID patients. You don't do anything with a COVID patient. It's treatment is what we call supportive, which means you treat their symptoms. So for most people, that means they've got a cough, so you treat their cough. Maybe they have blood clots, you treat their blood clots. Like, okay. there's nothing to this, really. Like, it's not educational. You're just there staffing these rooms because somebody needs to, and that's it. So you're not getting a lot of education out of it. And I will say that, like, my program in particular was very good about putting us in high level cases that we, like, during the day, at least, where we would, be using our time well. We very rarely were used just purely for grunt work. I mean, there's plenty of grunt work involved, don't get me wrong, but, like, most of the time, they were just like, yeah, like, you're doing this massively complex case on this super-ass sick person, so go for it. I mean, it's a huge issue, and I think it's getting a little more press than it used to, at least. But I mean, it's just nuts, dude. It's so nuts. But yeah, with COVID, like, especially all of the residents who are, kind of like on floor care, like hospital duty, like internal medicine residents and stuff, they're just in these COVID units and, like, doing nothing. Just watching all these people who are, doomed to ride their endotracheal tube until their life finally ends. So I think, like, as we discussed at some point, the mortality for, like, if somebody winds up in the ICU with COVID and needs a breathing tube, your mortality is huge. It's like, it's well over 50%. I think I saw more like 70. And that, in my experience, is, probably pretty close to what it actually is. And those people, like, you can't do anything for them, really. You just kind of, maybe you can position them, or, sometimes they need a bronch, like, you can have a look in their lungs and, like, clean out some shit in there or whatever. But for the most part, there's nothing to be done. They're just there, breathing. Breathing on a machine until they die. And, I mean, that's, like, super morbid, but that's the reality, dude. Like, if you get that sick in the first place, you're just sort of doomed. Yeah, and that sucks for residents because, again, like, they're going to be they're being used as the frontline workers because they're cheap. It's easy. They can't say anything about it. And, like, that is not an educational thing to do, let me tell you. Yeah, so we've talked about work hours. We've talked about how, basically a lot of the time it's kind of borderline unsafe what they have you do, and, like, the mental stress, the out-of-work stress. The other thing we need to talk about is kind of the shit rolls downhill mentality that you're treated with. And we've, sort of, I have mentioned that multiple times, but really, like, as a resident, people still, like, refer to you as doctor and stuff, but functionally you are the bottom of the totem pole. Like, there's med students, and people, like, basically disregard med students, and it's not that, like, what's a good way to put this? Just nobody gives a shit about you. Honestly, like, you're just kind of there, but residents, like, people, like, actively disdain you. Like, a good example is if you were to get in conflict with a nurse, and my experience with academic nurses is not a good one. My experience was that they are essentially trained to call residents for literally everything and not encouraged to, like, think critically or take care of anything on their own. Like, I honestly can't even remember ever getting called in residency, like, even with something simple like, hey, this patient has nausea, can I give them 12.5 milligrams of Finnegan? Nothing like that. There's no, like, thought process whatsoever. They just call you and say, hey, this patient's nauseated. That's it. Not even like, what do you want to do? Do you think they need anything? Here's their blood pressure. Here's their other meds they're on. Nothing. Just, they're nauseated. And it's up to you to figure everything else out. That's the standard they're taught to hold, Like, there's no, like, accountability, nothing. And if you complain about that, or you get pissed about it, especially if you get pissed about it, then you hear about it from administration because they report you, like, instantly, no questions asked. And, if you're like, well, she's taking care of this patient, I'm covering 70 other patients, I know nothing about them, she gave me zero information, it's 2 a.m, what the fuck do you want me to do about it? They're like, well, figure it out. There's the fact, like, you're just not cared for. And there's, again, plenty of, like, old school attendings who, like, I'm pretty sure stay in academics because they enjoy busting people's balls and feeling superior to other people. Like, there's always a few, or there's, like, you'll have some conference that you go to weekly, and it's always the same, like, 3 or 4 people asking the residents questions. What's the fun part? There is no fun part. The fun part is that it ends and you make a good living afterwards. There's zero fun part to residency. But yeah, it's always the same few people who are just kind of, like, crapping on you you know, on the residents while they're presenting something. And you can tell that they enjoy it. You know, they really, really enjoy like putting you on the spot. And it's everywhere. It's everywhere in every program. There's always somebody not paying tuition. Yeah, not paying tuition is fun, but guess what? You get to pay your tuition for a long time after residency ends. It just doesn't sound like tuition. It's a loan payment, not a tuition payment. Anesthesia residency is it's terrible. Anesthesia residency is terrible, but it's probably better than most other residencies, honestly. The hours are probably middle of the road to below average as residency goes. And the training is actually more useful. It's a lot easier to make anesthesia residency useful than it is a lot of other residencies. Yeah, but like my training was very, very good. But it could definitely be better. It could be done better and much more efficiently, like especially in terms of like work structure. You know, if I spent the same amount of time there, but like under less duress, like especially at night, then that would have helped my learning a lot. And if the environment has been, you know, a little bit more collegial, where the nurses aren't just like expecting you to do everything all the time. Like here's an example. In real life. So when somebody has an epidural, like anybody, I guess, usually it's pregnant women have an epidural, like, you know, you take it out when the baby's done. Literally everywhere that I've ever been, the nurse takes it out because all you do is pull it. It's just, there's nothing like adhering it in. It's just like you pull this little tube out. It's nothing. They would call us, the OB nurses would call us whenever somebody delivered their baby to come and pull that out. Pull the epidural out. It's like, so we have to get up, you know, walk down this big long hall. Like, it was about a 5-minute walk up to OB. Like, you walk down a hall, go up to the 5th floor, walk down the OB hall, and go do this. Which doesn't sound like a whole lot, but that's, you know, they wake your ass up, and, like, for nothing. You know, they could stand there and just literally pull it out without calling you. Why didn't you just tell them to pull it out? Because that's unacceptable. That wasn't the hospital's, like, how the hospital operated. They wanted you to physically go up and do it. Which is just fucking ridiculous. And that is actually a great example of how hospitals treat residents. It's like, yeah, you pay this nurse up there and, like, what is she doing? She's not doing anything, right? She's getting on the phone at 2 a.m. to call the resident to walk upstairs to pull out the epidural. Like, she is already in the room talking to the patient. It would literally take her 3 seconds to do. If that. You say, hey, lean forward a little bit. Yoink. That's it. But no, wake the resident up. Have them do it. It's insane. It is absolutely insane how residents get treated. Like, you're subhuman. It's fucking crazy. After working a full day, you get paid like $8 an hour. Well, I got paid like $13 an hour. I mean, this is just kind of the reality that, you know, if you know, like, I'm not trying to, you know, make you guys like down on what's coming your way. Just be aware of it. Like, that is the culture that you're getting into. And so to have like I mean, who knows who came up with like National Residence Day? Like, I'm sure that's like some administrative nonsense somewhere. They're like, we should have Residence Day. Let them know how much we appreciate them doing all of our work very, very cheaply for long hours. We'll buy them a sandwich today while they're at work. And I mean, the only reason that I can really think of that it would still be this way after so many people have gone through it is spite from mean ass people who have gone through it, who want other people to suffer, and money. Mostly money. Well, boys, it's 11 o'clock. I gotta go to bed because my kid is up bright and early, whether I want him to be or not. Yeah, I'm on vacation this week, so maybe we'll get a daytime stream in. Who knows? Who knows? So yeah, thank you guys again. I will see you Wednesday, if not sooner, and have a great week. Take it easy, everybody.